I would like to thank the health system for giving me this opportunity to be here and to talk about delayed cord clamping. And this is a pretty hot topic in neonatology. And I just wanted to share with you the current research work and what we are actually doing in university, and how we can reduce actually the transfusion burden in this preemie population. Right. So the title of my talk is Delayed Cord Clamping in Preterm Neonates and Benefits of Placental Transfusion. I have nothing to disclose and no conflict of interest. So the objectives are the following. So I'm going to first provide a background information regarding red blood cell transfusion exposure in the neonate, especially a premature neonate. Review literature describing transfusion preventive strategies, including placental transfusion, and present a protocol for delayed cord clamping in preemie babies not requiring resuscitation. So I'll start off with the background. So we had admitted a mom who was 27 years old, preemie gravida, admitted at 24 weeks gestation. It was a preterm labor. She had history of PPROM and choreo. She went on to deliver a male infant. It was a C-section for fetal distress with 610 grams birth weight and Apgars of 1 in 7. So the baby required resuscitation, got intubated, got surfactant, and volume resuscitated. So the admission crit was 25, and this baby received 2 red cell transfusions within 24 hours. But as you can see, the 24-weeker had a prolonged, complicated course, required 100% oxygen, was on inotropes, developed grade 3, grade 4 IBH. And during the course of the NICU stay, the baby received 14 transfusions in the first 2 weeks of life and totally received 66 red blood cell transfusions and was exposed to 12 different donor blood units. Now, this is an extreme case, but in an average number, I mean, if you're born premature at 24 to 25 weeks, you're going to be expecting anywhere from 10 to 12 red cell transfusions during the NICU stay. And we'll also show you some University of Maryland data. So transfusions in the NICU, which is definitely a life-saving therapy. It's indicated for severe anemia or bleeding. It's very common in less than 1,500 gram babies, more so common if you're an ELBW, less than 1,000 gram babies. And the main indication, as I said, was anemia of prematurity. And premature babies, they drop their hemoglobin, and the nadir is going to be around 4 to 6 weeks of gestation, when the hemoglobin is going to hit low at 7 to 8 grams. But there are multiple reasons for this anemia of prematurity. But I think the most important is the phlebotomy losses. We frequently don't pay so much attention to that, but phlebotomy loss is right up there. There's also decreased erythropoietin production, as well as increased hemoglobin clearance because of the short lifespan of the red blood cell. So just to give you a snapshot about the phlebotomy losses, and this was actually a study published in 2012. So when they looked at 14 VLBW babies and accounted the blood loss, and depicted in black as well as in white bars, is a combined blood loss from 14 very low birth weight infants from the first 28 days of their life. And the volume comes to about 70 mLs per kilo, and that is approximating the blood volume of this premature baby. So it is a significant amount of blood what we draw from these babies, and which we are replacing as red cell transfusions. And the majority of these phlebotomy losses occurs in the first week of life. So as you can imagine, in a 500 gram baby, who has a blood volume of 80 to 100 ml, so the blood volume is going to be 40 to 50 mLs. And the blood loss range in the first week is anywhere from 10 to 20 ml per kilo. So if you're drawing 6 to 7 mLs from a 1 kilo baby, that approximates to a 450 ml blood loss of an adult. So these admission labs on day 1 especially contributes a lot. So maybe up to even 10% of the blood volume. Now, just like to highlight, the patient blood management in the U.S. So, as you know, the taking care of babies is now becoming more and more sophisticated, and especially in the last 20 to 30 years, we have seen so much advances in technology that we are coming across, more complicated, life-saving, and aggressive procedures, but which also means that you're going to be transfusing a lot. Now, in the US, the demand for blood has actually increased. So over 30 million units of blood products are being transfused to 4.5 million patients. And the blood demand increased by 27% just over 94 to 2001, and it's increasing at a rate of 3 to 5% per year. So we have to come up with blood conservation techniques, have appropriate transfusion practice, and all this improves patient outcomes. So it all starts with us. So why do we transfuse babies? As you know, red blood cells are oxygen-carrying cells, and oxygen binds to hemoglobin. So when you are going to increase the hemoglobin, you're going to increase the arterial oxygen content. So you're increasing the oxygen bound to hemoglobin as well as the amount of oxygen dissolved in the red blood cells and plasma. So that's going to translate into increased circulating blood volume, you're maintaining blood pressure. So ultimately, you're improving tissue oxygenation, basically the cerebral tissue oxygenation, because we worry mostly about the brain. I mean, of course, kidney oxygenation, cardiac oxygenation, everything is important, but ultimately it's the brain. So there's increase in regional cerebral tissue oxygenation, and that's what red blood cells provide. But transfusions are not without risks. There's always a risk of infection. Granted, the infection risk is small, but there is still a risk of hepatitis B, HIV, CMV. You can have parasitic infections, babesiosis. All those are rare, but still there is a risk of infection. Transfusion reactions. We don't see it much in the neonatal population, especially also the graft-versus-host disease, because in the neonates, we are going to leukoreduce them, and we are going to irradiate the products. So the blood bank irradiates red blood cells just before dispatching for all babies less than 1,500 grams, as well as the hem-onc patients or the immunosuppressed patients are going to get irradiated blood that reduces the graft-versus-host disease. And there's also a risk of donor antigen exposure. So in our case, there was more than 12 different donors, even though you have dedicated pedipacks. So normally what happens is when a donor walks in, once a donor blood is collected, it's going to be aliquoted to pedipacks of either 4 or 5, and you have a designated donor for an ELBW infant. But sometimes ELBWs, they need more fresh transfusion, or if they're actively bleeding or in DIC, so they're going to use a fresh product rather than a product which has been sitting on the shelf for 30 days. But usually the shelf life is up to 42 days for adults. For babies, it's up to 35 days. And there's also toxic metal exposure, so I would like to allude to lead. So heavy metal lead, and we have published that heavy metal lead is present in donor blood, so it actually warrants occupational health screening if a patient is going to walk in, especially in areas where lead exposure is high, or if your occupation is such that you're exposed to lead, you need to screen that donor blood for heavy metal lead. So transfusion-associated morbidities. So intraventricular hemorrhage, there's an association with early red blood cell transfusion, especially in the first week of life. But there are also reports of transfusion-associated gut injury or necrotizing enterocolitis. So there are reports where within 48 hours of red cell transfusion, you see a bloody stool, abdomen distension. So there is still no causation, but there's a lot of research going on of the association of red cell transfusion and neck. So that's why in some units, NICU units, they stop feeding when they transfuse. In our NICU, we do not. We continue to feed the babies. We don't have an NPO policy when you're giving transfusion. So, but we do give 15 mLs per kilo over 4 hours, and it's a slow transfusion. And again, it's also attending dependent, but if you have a hemodynamically significant PDA where you have a diastolic runoff and there's a risk for mesenteric ischemia, so you may make the NPO during a transfusion. But it is not standard policy to make the baby's NPO while giving transfusion. And then transfusion-associated lung injury, there are a few reports in newborns, but it's more so in the adult population where we see trolley. So to highlight the transfusion burden in university, so we looked at a retrospective data over a 5-year period, and we had 560 BLBW infants. Out of that, 403 babies received at least 1 transfusion. And then we categorized them based on birth weight, gestational age, gender, and 2-year periods. And what we found was out of the 270 babies who were less than 1,000 grams, 242 babies received at least one transfusion. So 90% of them received a transfusion if you're less than 1,000 grams, and a mean number of transfusions were 12. And that dropped to 55% if you are greater than 1,000 grams. And the mean was about 2.4 transfusions during the hospital stay. So similarly with the gestational age, 93% of babies less than 28 weeks is going to get at least one transfusion. And the mean transfusions, again, is close to 12 transfusions during their NICU stay compared to gestational ages greater than 29 weeks. And we did find a little bit of a male preponderance, but when we compared the two-year periods, we found there was no change. The transfusion rates remained high. And this was the basis for establishing transfusion guidelines. So, we in our group, spearheaded by me, we came up with transfusion guidelines. We looked at this, and in January 2017, we established red blood cell transfusion guidelines based on hematocrit, based on respiratory support, based on FiO2, and physicians and nurse practitioners, when they order a red cell transfusion, they have to justify why they are ordering red cells. It is just not enough that you mark anemia, but you need to mention what the hematocrit, what is the respiratory support, is the baby on CPAP or oscillator, if the baby is on cannula, is it less than 2 or more than 2 liters, and what is the FiO2. Because we have different hematocrit thresholds based on the FiO2 of less than 40% or greater than 40%, and also symptoms of anemia. So in our electronic system, EPIC, we have a physician order entry which creates prompts. So I'm hoping these guidelines are being followed, so we'll know in summer. A med student is going to be looking at the compliance of these guidelines, whether it's different in the resident group or nurse practitioner group, or hey, these guidelines are there but nobody's using it, so we should revisit it, or we don't know. So we'll have to see what's going to happen based on our objective data. Now, our transfusion burden is not very different nationwide. This was published in 2006 from Janssen. So it's kind of 90% of babies less than 1,000 grams, or 94% of the babies of ELBWs are going to be transfused. So now we know that it's not unique for NICU babies, it's life-saving, it's standard protocol, but what are the ways in which we can reduce the red blood cell transfusion? And this is where I need to, this is where I wanted to talk to you all about delayed cord clamping, about placental transfusion, what are some of the preventive strategies we can do. Transfusion is not avoidable. You are going to be transfusing babies, but we can at least reduce the number of red blood cells. You can reduce morbidity, and it's also there's a cost factor involved too, and nationwide, some of the hospitals, when they have followed guidelines and delayed cord clamping, they have made a difference in the red blood cell use. So some of the preventive strategies is the delayed cord clamping and umbilical cord milking. I'm going to be talking a little more in detail about these two strategies. Briefly touch upon blood draw from umbilical cord for initial lab workup. So that way you can save blood. It's a lot of blood. It's about 4.5 mLs of blood if you're going to include multiple tests on day one, for admission labs. If you can try to get from the umbilical cord, you can reduce that phlebotomy loss from the baby. Talking about establishing transfusion guidelines and limiting phlebotomy losses. So let me start off with delayed cord clamp. So in the 1950s was when actually it changed. Centuries ago, when a baby is born, the practice was to clamp the cord only when the cord stops pulsating. And then it came down to 5 minutes, and then it came down to 3 minutes, and then after the Virginia Apgar, to improve the third stage of obstetric management, that actually prompted earlier clamping of the cord, and also to reduce the effects of maternal anesthesia on the baby, so it became shorter and shorter. And of course, now with advances in neonatal management, and better resuscitation, so it was felt that the sooner you separate the baby from the mom, you're going to be quick at resuscitation. So early cord clamp literally is clamping the cord anywhere from immediate to 15 seconds, where there is still significant circulation occurring across the umbilical vessels. What about delayed? So delayed is how soon after birth should you delay to apply the clamp? Now this is a very easy question, but no simple answer. It's been debated globally, and it's anywhere from 30 seconds to 3 minutes. So it depends on which organization you ask. So World Health Organization would say 1 minute to 3 minutes. I'm going to present data from our country, and that's going to be anywhere from 30 seconds to 60 seconds in the US. So, but if you look at the definition, it's anywhere from 30 seconds to 3 minutes. But if you look at the midwife literature, it can be up to 5 minutes or till the cord stops pulsating is the definition for delayed. But delayed clamping is where there is still passive transfer of warm oxygenated blood. This is contributing to an additional blood volume at a very slow rate. It's physiologic. So it's a passive physiologic transfer of blood volume, mostly facilitated by uterine contractions. What about umbilical cord milking? Whereas cord milking is more an active process. Unlike delayed cord clamping, it's passive. This is active. It's an active process of squeezing the blood down a segment of cord. So usually it's about 20 to 30 centimeter segment, and you milk it about 3 or 4 times before you clamp it. Again, this is not physiologic. And clamping has its own indications, own benefits, and the downsides are still debated, but I will definitely brief that. So talking about delayed cord clamping. So this is a snapshot of the placenta. So placenta is an organ which is filled with blood. And the main function of the placenta is it's a physiologic lung. So in the fetus, the fetal lungs receive only 15% of the cardiac output. And the majority of the rest of the cardiac output is actually going back into the placenta, so where gas exchange takes place. And what's coming out of the placenta is the umbilical cord, as you all know. There are 2 arteries and 1 vein. So the umbilical vein is carrying the oxygenated blood into the right ventricle, and in the right ventricle, it shunts across the foramen ovale and goes into the left ventricle and supplies the rest of the body. Now, the goal of the placental transfusion is the transfer of blood volume from the placenta to the newborn. So the umbilical artery is muscular, and it's going to close off, it's going to spasm, and it's going to close off in about 20 to 25 seconds. In fact, there's negligible flow coming back from the baby to the placenta after birth. So this is a normal, natural process. But a vein, which is thin, less muscular, remains patent. And this facilitates continuous transfer for even up to 3 minutes to facilitate transfusion of blood from the placenta to the infant. And the placental transfusion absolutely ceases by 5 minutes in 95% of the babies. So this is just a cartoon to tell you that the fetal blood, the fetal blood volume or the neonatal blood volume increases as you delay the time to clamp the cord, and the placental blood volume is actually going down. Okay, so it can be, if you're going to clamp the cord instantly to up to 15 seconds, the amount of blood remaining in the placenta can be as high as 90 mLs. But if you wait up to 60 seconds, you can drop it to 60 mL. So which means that you're going to ultimately trash the placenta. So before you trash that, the volume of blood, that's a rich source of immunoglobulin, stem cells. It's a rich source of red cells, which are oxygen carrying cells, and iron. So it's all going to benefit the baby. So the placental transfusion volume can be anywhere from 25 to 50 mLs per kilo. Okay. Now, what are the factors which determine the placental transfusion volume? So I'm going to go over individually each of these. So the uterine contractions, the umbilical blood flow, the time of cord clamping. So what happens to the volume at 15 seconds? What happens at 30 seconds? What happens at 60 seconds? And people have done research to calculate the volume which goes into the baby. What about the effect of gravity? If the placenta is above or below, or it should be at the level of the introitus? What about C-section? What about vaginal births? And what about breathing? Now this is huge. For the last year, a lot of research has been done. When should you cut a cord when a baby is trying to breathe? Should you let the baby breathe and then cut the cord? What is the physiology behind it? Or or just cut the cord and then do resuscitation? So I'm going to touch upon a few things about that. Okay. So this is actually a cartoon showing the benefit of the placental uterine contractions. So when the placenta, when the uterus contracts, it squeezes the placenta, which is a blood-filled organ, and the pressure can go up to 100 millimeter mercury, and that goes directly into the umbilical vein. Okay. Now the backflow usually does not happen after 30 seconds because of the spasm of the umbilical artery, reducing the reverse flow back into the placenta. So the umbilical venous blood flow is predominantly the source of the preload for the left ventricle because it is shunting across the foramen ovale. Now the timing of the cord, so if you give about 60 seconds, there's going to be more passive transfer. You wait for up to 3 minutes, there's going to be more emptying of the placenta and more blood flow to the baby. Okay. Now the onset of spontaneous respiration with the negative intrathoracic pressure, what happens is oxygen is a powerful pulmonary vasodilator, right? So you have fluid-filled lungs inside the uterus. Now when the baby is born, takes a breath, all that fluid gets replaced with air, with oxygen. And oxygen reduces the pulmonary vascular resistance. When it reduces the resistance, what happens is you're increasing the pressure gradient. You're increasing the pressure gradient between the placenta and the physiological sink, which is the lungs. So more blood is going to go fill into the lungs and establish pulmonary circulation. Okay, and you'll be hearing in next couple of weeks about NRP. So NRP's focus historically has been more about providing adequate oxygenation, ventilation, what kind of ventilatory support you need to give, how much of oxygen you need to titrate. But now the focus is also shifting to placental circulation. So as much as your ventilation and oxygenation is important, so is establishing the circulation and letting the breathe. And if you understand the pathophysiology behind it, it's easier. Okay, and also the effect of gravity. Okay, so when you delay to some more pictures here to depict the same physiology, just enforcing it. So when you delay the time to apply the clamp, so the blood which is coming from the umbilical venous source, 2/3 of it is entering into the right ventricle. Okay. From the right ventricle, it's going into the pulmonary artery and it is going into the lungs. But 1/3 of it is going across the PFO, and it's a source of preload to the left ventricle. So the left ventricular outputs is now the source of the left ventricular output is your umbilical venous blood. And the left ventricular output is directly going into the carotids and into the cerebral circulation. Now in the scenario where your cord is still intact, you have not applied the clamp, and the baby is trying to breathe, the umbilical venous blood is actually a source for your, it's going into the physiological sink, the lungs. The lungs is now filled with air. So more blood is gushing. So you have established the pulmonary circulation and more blood is returning into the left ventricle. Okay? So the preload of the left ventricle is now the pulmonary venous blood until the lungs take over. The umbilical venous blood is the source of the preload. Okay? So this transition is smooth. Now imagine if you clamp and you shut off. There is going to be a drop in this preload. And then you're letting the baby breathe, and suddenly now the left ventricle sees all that blood. So the preload of the left ventricle is now the pulmonary venous blood, and now it gushes into the carotids and into the cerebral circulation. Now this may be okay in a term baby who's breathing well. But imagine a scenario where you have a preterm baby who's struggling to breathe. There are going to be wide fluctuations in pressure. You want to try to minimize the wide fluctuation in pressure, because these wide fluctuation in pressure could precipitate intraventricular bleed in extremely premature babies. So allowing the umbilical circulation to contribute the preload to the left ventricle, from there to the aorta, you're reducing the dynamics of pressure changes. And after the ventilation is established, the pulmonary venous blood entering into the left ventricle is now the source of the preload, and everything goes smoothly, and then you clamp the cord. So, so based on the timing of the cord, if you're going to immediately clamp the cord, about 67% of the blood volume is entering the baby. But if you wait up to 60 seconds, you have an additional boost. And the volume of blood remaining in the placenta is going to go down further. And you wait for up to 3 minutes, you're going up to 87%. So it's all telling you that longer you delay, the more blood transfusion to the baby. Okay. So this additional blood volume is, as I mentioned, improvement in right stroke ventricular volume, pulmonary blood flow, and it all translates into increased preload and increased systemic flow. So based on the gravity, they found that 10 centimeters above and below the introitus should be okay. But you don't want to go too high or too low. Then you're applying tension to the cord, whether it's above or below, and it's going to constrict. So either placing on the maternal abdomen or between the legs in C-section. So we don't do delayed cord clamping for C-sections here. I mean, the place where I am currently at. But there are some institutions who do delayed cord clamping on C-section delivery. So it's a comfort level, it's a room space, so many factors play into account. So position of the baby, not too far away from the introitus, delayed cord clamping is feasible. Okay. So, and then I wanted to share this study about ventilation before delayed cord clamping, and what is the evidence behind. So I'm going to show you an animal study first, and then the human study from UVA. So, so in the animal studies, what they found was, so the open circles are the ventilated lamps. And the black circles are the unventilated lamps. So what they did was they measured the right ventricular output, and as you can see that when the cord is clamped, there is going to be a drop in the right ventricular output. But that is mitigated if you let the baby ventilate first, because ventilation creates this negative pressure gradient, and more blood is flowing into the right ventricle. So the drop in the right ventricular output is not happening if you're going to ventilate first and then clamp the cord. And that basically also translates into also the pulmonary blood flow. So the pulmonary blood flow is actually shut off if you clamp and then ventilate. But if you let the baby ventilate and then you clamp the cord, this drop in pulmonary blood flow does not happen. So you're establishing the circulation well. So placental transfusion is actually accelerated by the onset of breathing. So this is the pilot study of feasibility and safety I was talking about in premature babies. So they exactly found these animal studies, and they said, okay, delayed cord clamping improves blood transfusion. So what about in babies who really need resuscitation? How do we do that? So they looked at 29 babies, not 19, sorry, 29 infants between 24 weeks and 32 and 6-7 weeks. And their concept was establishing lung inflation and pulmonary circulation prior to cord clamping leads to smoother transition and reduces the risk of IVH. And the study was led by Dr. John Catwinkle, who is also one of the NRP liaisons. And he was my mentor in my previous institution. So he did the study and showed that it is possible to resuscitate with the baby still being attached to the baby. To the mother, sorry. And so they had a vent first pole, and they also had a vent first table, and they did 90 seconds of delayed cord clamping, and when they were either doing PPV or CPAP. And what they found was a 5-minute UpGuard. None of the babies had heart rates less than 100, and the cord blood gases were all similar. So again, this was just a small study to show feasibility that's doable, and that was published. So it was a small pilot study. So the AAP came up with this news in 2013, don't rush to cut the cord. And new recommendations call for delayed cord clamping in premature babies. So sick and preterm babies are likely to benefit most from the additional blood volume which is achieved by delayed cord clamping. But there's a legitimate concern is that are you delaying the resuscitation, the timely resuscitation? Because you're clamping the cord immediately prevents acquisition of adequate blood volume, potentially harming the infant. So this Cochrane review, there was a systematic review from 15 trials, basically combined early clamping of the cord, which was up to 15 seconds, to delayed clamping. They also included a little bit of cord milking studies as well, and uniformly they found only benefits. So there is a reduced risk of intraventricular bleed. Granted, it's all grades. It's grade 1, grade 2, grade 3, and grade 4. We worry more about grade 3, grade 4, but they link to all the 4 IVH. There's reduced inotropic support for low blood transfusion, reduced blood transfusions for hypotension reasons, reduced transfusions for anemia, reduced sepsis, and reduced NEC. Because these are cord stem cells, there's more immunoglobulins, so there are a lot of benefits to the placental transfusion in preterm babies. So the ACOG put a statement this year in January 2017 recommending waiting for 30 to 60 seconds when feasible before clamping the cord in vigorous term and preterm infants. Both AAP and NRP has endorsed this, and this is actually not new. Way back in 2003, the Federation of Obs and Gynae came up with delayed cord clamp. The midwife group, they wanted the delayed cord clamp, and again, the LCOR and the WHO in 2014 mentioned a delayed cord clamp from 1 minute to 3 minutes for all term babies. And so AAP has now, AAP and NRP has endorsed the delayed cord clamping. So what about delayed cord clamping in term babies? My focus is more on premature infants, but in term babies, definitely you're giving so much red cells, there's going to be lower frequency of iron deficiency anemia, high ferritins, and higher birth weight. So this is huge outside the US in developing nations. So the iron deficiency anemia in certain countries can be as high as 50 to 60%. And by giving extra blood, the first 3 minutes, you're giving you're stocking up the baby with ferritin and iron for up to 6 months, 6 months to 9 months. So an iron deficiency anemia, as you know, has cognitive issues. There are lower scores if you're going to be anemic. So, and especially in developing nations, where you're packaging iron and giving iron fortification, so you're reducing the cost. So this is a very cheap, safe, easily available technique for reducing the iron deficiency anemia as well as morbidity in developing nations. Now, what about in developed nations, where we are going to be seeing more hyperbilirubinemia? Are you, more phototherapy days, because of polycythemia? Are you increasing hospital costs, because you're going to be ordering more billy blankets and delaying discharge? So they have done studies, and they have shown only a slight increase, and none of the studies is saying that it is a significantly increase in hospital cost or there are incidents of kernicterus. There have been no incidences of kernicterus as far as I know, and as far as the studies what I've looked at and what WHO has shared. But again, more to come. I know there are a lot of studies exactly looking at the hospital costs from hyperbilirubinemia treatment. But it looks like there is the burden of iron deficiency anemia may not be as high as in developing nations, but there is still pockets of iron deficiency anemia which has to be addressed. And so that's why AAP is advocating for healthy term babies 30 to 60 seconds for delayed cord clamping. Okay. So more recent evidence, and in premature babies, the risk of hospital admission or death was higher among babies whose cords were clamped before they were able to take spontaneous breaths. So, but that risk of mortality actually reduced by 20% for every 10-second delay in cord clamping after the breathing was established. So what about obstetric acceptance? So outside the US, the obstetric acceptance is higher, especially countries from Netherlands and Switzerland, France. 44% of premature vaginal deliveries and 37% of preterm C-section deliveries, acceptance is higher in C-section outside the US. So in the US, 53% of OB thought timing of umbilical cord is very important or moderately important, but 76% had concerns about resuscitation, citing delayed NR as a neonatal resuscitation as a reason to clamp the cord immediately. So what about other concerns? What about the risk of postpartum hemorrhage? Is the mom going to bleed a lot, or is there going to be less of postpartum hemoglobin and now be jeopardizing maternal health? So the Cochrane review from 2013 looked at 15 trials, and there were almost 4,000 women infant diets. So there was no significant difference in postpartum hemorrhage less than 1 minute as well as up to 3 minutes when they compared, and not associated with the difference in postpartum hemoglobin or the need for red cell transfusion in the mother. So they consolidated it, and that's why the ACOG came up with the statement this year. So cord milking is more an active squeezing. This is not physiologic. And greater volume of placental transfusion can be achieved, but this is going to benefit the babies, especially who are crashing, who could benefit from the extra blood volume, but then you're not comfortable waiting for up to 30 seconds or 60 seconds, because waiting those 30 seconds can be like as though you're waiting forever if you have done delayed cord clamping and waiting for the baby to breathe. But then some of the OBs would just squeeze the cord, and again, it's the same. Yes, exactly. Stop. Yes. But again, this is debated because you are pushing all that blood into not only the right ventricle, but you're also pushing into the left ventricle, right? And the left ventricle is going to directly transmit all that pressure into the carotid and the cerebral. So what it means is it's like giving a bolus, an unphysiologic bolus. And would you be precipitating intraventricular bleed? So that's why both AAP and NRP and LCOR is not recommending milking for preterm and for routine deliveries unless in a research setting. So that's their take on that. So, but just little for more theory behind the milking, they have actually looked at segment of 30 centimeter segment of umbilical cord, how much blood is there, and three of these studies have shown it can be anywhere from 8 to 28 ml of blood volume, and these are blood volume in a premature cord. I'm not talking about a 40-week cord, but how much of blood is going to be there in a 23-week cord or a 34-week cord. So this is what they found. They calculated it, based on Doppler and the size of the umbilical cord. Now there are two ways of milking the cord. One is milking the cord with the cord still attached to the baby, but the other mechanism is where the cord is disconnected from the mom, but you have a long segment of cord which the OB give, and then you milk that strip, and then you actually clamp the cord. Okay. And all this review is also there in Journal of Perinatology, and the Kataria group and Rouben group have done extensive research on cord milking and cord delayed cord clamping, and all these references are from that. So, but it achieves the same purpose of higher hemoglobin, higher mean blood pressure, and shorter duration of ventilation with lower odds of requiring red cell transfusion and IVH. So the Rouben group and the Kataria group, they compared in cesarean section deliveries, and these were the mean gestational age of 28 weeks. They had 75 premature babies assigned to the cord milking group, and 79 babies assigned to the delayed cord clamping group. And what they found was there is improved systemic flow and perfusion in premature babies delivered by C-section more efficiently than delayed cord clamp. Because remember, in delayed cord clamp, you're dependent on the placental contraction, but with C-section deliveries, you don't have that. And cord milking may be beneficial in C-section deliveries in premature babies. All right. So, but the current recommendation is against the routine use of umbilical cord milking for babies less than 28 weeks because of insufficient published human evidence of benefit. So, and cord milking is to be considered on an individual basis or in a research setting. And this is just a snapshot of how many studies are undergoing right now as we speak on delayed cord clamping and delayed cord milking. It's a huge hot topic. All right, so this is our delayed cord clamping protocol in University of Maryland. So we have finalized the protocol now. Before we started implementing, we actually educated the full group, which included the OB group and the NICU group. And the NICU group was NICU faculty, NICU fellows, NICU nurse practitioners, NICU nurses, NICU respiratory therapists. And from the OB group were the midwives, besides the OB faculty and the OB house staff. So it was just a quick 10-minute, 10-slide PowerPoint of what is delayed cord clamp, why is delayed cord clamp being promoted, and how do we do it, and what are the downsides. So here I would like to focus. We are doing delayed cord clamp only for more than 28 weeks and less than 37 weeks. We are not promoting delayed cord clamp for less than 28 weeks, mainly because of the nervousness among our faculty, and there was no consensus. There was consensus only for 28 weeks to 37 weeks. And if the mom is stable, and if the baby is stable, and if the you're going to assess for tone, cry, and respiratory effort, and you're giving gentle stimulation. We have a thermoreg wrap on top of the blue towels, and we would start the delayed cord clamp process. So you introduce yourself and you say, I'm Dash from the NICU. I'm here to assist with delayed cord clamp ahead of time, making sure you don't have those contraindications listed on the left. We do have the automated digital clocks. And you call out. It's 15 seconds out, 30 seconds out, or 45 seconds out. It's 60 seconds, clamp the cord. But anytime you can interrupt the cord clamping process. If the OB doesn't feel comfortable, or the NICU team doesn't feel comfortable, we are going to interrupt the process. And then the infant is actually transferred to the pediatric provider, and routine resuscitation is carried out. So this is again another mnemonic, and so we are making charts and putting that next to the NRP guidelines, so we'll be laminating it. So it's basically tell the team what you plan to do, request supplies, assign roles, note the time of birth, start the timer, call out the time, transfusion period, stimulate the baby, stop and clamp the cord, and evaluate the baby. Okay, so just a few words about umbilical cord sampling. So this is another technique to reduce blood loss in babies, is drawing blood from the remaining umbilical cord or placenta. And it's been extensively validated. I just want you to show the evidence behind doing that, and reduces the transfusion need in the first week. So if you think, day one, you're going to be drawing blood for CBC, blood culture, type and cross match, glucose, blood gases, and metabolic screen. It comes up to 4.8 mLs. It's a lot. And that you can reduce that much amount of blood draw by drawing blood from the umbilical cord. Again, this is another practice change. I don't know how much blood will remain in the placenta if you're going to do the delayed cord clamping. So, and again, there are other people in the university who are also interested in cord blood for cord stem cell research. We don't know how much of blood will remain in a preterm cord versus a term cord. So there are a lot of challenges. It is one of the proposed mechanisms for reducing the blood draw from the baby. So you basically prepare the placenta, you prep the, the placenta is placed there, and cord is prepped, and you draw using an 18-gauge needle. So these are some of the studies where they looked at 20 very low birth weight babies, where they drew blood from the cord and blood from the baby for admission labs. And you can see the number of transfusions in the cases where the blood was drawn from the cord is far fewer compared to if you're going to be drawing blood from the baby. And so what about CBC differential hemoglobin and platelet counts, they all correlate. Whether you take down from the, from the baby versus the cord. And the same thing also with the blood culture. So my take-home message, placental transfusion is a large reservoir of fetal blood, and delayed cord clamping is the recommendation now for 30 to 60 seconds for babies not needing resuscitation. Decreased iatrogenic blood loss, and improved monitors, as it was pointed out, having a phlebotomy protocol, point of care test using iStat analyzers, you can reduce blood loss, establish transfusion guidelines in the NICU, and monitor the compliance through QI projects, so you can keep track. And I think implementation is one. You implement, and if you don't periodically go and assess, it's going to be very easily forgotten. So you'll have to have a system in place where you're going to, you have to have a dedicated person who's invested in this, and it's a group effort, and it's a culture change. So I'm very passionate about red cell transfusion, so and I want to make this practice change in my institution.